Hello, welcome. I'm Dr. Popovitz. Thanks for joining us again. Today I have the pleasure of having one of my oldest and dearest friends, Dr. Michael Mizhiritsky here, and my partner here at New York Bone and Joint Specialists.
Hi, everyone.
We're coming to you again from our brand new facility. That's an Avenue Midtown location. We're really proud of this location. So today we're going to talk about shoulder pain, but really a matter of, is it coming from the shoulder or is it coming from the neck? So often do we see patients, and a lot of times it's not so clear cut. And when patients come into the office, they say, I have a shoulder pain, but sometimes they'll point up here. And when I see that, almost immediately I can conclude that it's coming from their neck. So Dr. Mizhiritsky is a spine specialist, and I'm a shoulder surgeon, so I figured this would be a great conversation. Mm-hmm. So somebody comes in, my shoulder hurts, and they point up here. Yeah. What do you think of?
Well, again, shoulder pain, to some people, it could mean different things, as Dr. Popovitz mentioned, and he's pointing to the area in the upper back region, upper back / lower neck region, which is primarily muscular in nature, but certainly could involve other joints deeper down. So we need to assess and figure out what's going on. It may not be the shoulder whatsoever, even though the pain from the neck or the upper trapezius refers to the shoulder. It's not a shoulder pathology problem.
So let's say they come in, shoulder pain up here. What's the first thing you ask them?
This happened. How long have you had it for? And then we get into the more detailed, specific questions. Did they just sleep the wrong way this morning? Did they have a specific injury? Did they hit their head? Was there whiplash involved? So we get into more of a history, and then obviously we try to figure out to make sure there's nothing more serious going on, such as, is there any weakness? Is there any tingling or numbness? Things like that shooting down to make sure there's no nerve or possibly disc involvement.
Yeah, I got to tell you, when somebody comes in to me with shoulder pain, they point up here, that's one of the first questions I ask. Do you have numbness? Do you have electricity going down your arm? Do you have neck pain? Even though I'm a shoulder doctor, you know, up here, it's a bell. Typically, it's not really, even though it's part of the shoulder, it's more often than not a referred pain from the neck, or something of that sort. What if they do have tingling and numbness?
So tingling and numbness usually means that there's some type of nerve involvement, or a pinch nerve, in this case from the neck down. So, and the pinching of the nerve can cause the tingling numbness going all the way down into the fingers, and then we need to assess that and make sure that it's not a slipped disc or herniated disc that's causing this nerve compression.
There you go. So that could be a herniated disc. Shoulder pain coming in up here in the trap very well could be a herniated disc. Very well. Now, what if they've had it for like 2-3 months?
Well, really the question at that point is it getting better or getting worse, really the first thing. If it's getting worse, we're even more so concerned that there's involvement of the disc, especially in the younger athletic population. And who actually does not complain that much. If it doesn't go away, we really need to assess it. We need to assess it with a nerve test. We need to assess it with an MRI, X-rays, give them the right diagnosis, so this way we can actually address it and treat it the right way. And to touch on the treatments certainly would include physical therapy. More often than not, that should be enough to actually fix the problem. But sometimes we do need to consider a bit more aggressive treatments, such as injections, epidural injections specifically. Surgery is very, very rare for these conditions, so not to be worried.
So, and if when you examine them, what if they have weakness?
Well, weakness we're very, very much concerned about, especially, again, thinking if there's tingling, numbness, and a nerve-related issue, because the nerves, they go to the muscles, and if there's significant nerve compression, nerve damage, and you're appreciating weakness as a result, sometimes it could be such a big problem that it's going to be too late to reverse it. So we want to catch it to make sure that it's either, if there's very mild weakness, we catch it immediately, and hopefully the patient is seen soon enough that it doesn't last too long where it's not reversible at all. So we need a diagnosis.
Mm-hmm. So, for weakness, when it comes to the shoulder, it could be the pinched nerve, but it could also be a torn tendon in the shoulder. Those patients will come in typically with pain here. Typically, that pain is here. And then we evaluate them, and they may have a rotator cuff tear. The questions there would be, did you have any trauma? Or if it's an older person, has this been gradual building up? Because a rotator cuff tear can occur suddenly from a fall or lifting something too heavy or any kind of traumatic event to the shoulder. But it also can occur degeneratively. As time goes on, people develop little spurs in the undersurface of the bone up here. And when you raise your arm, that scrapes against that tendon, the rotator cuff tendon. Eventually, the scraping may tear through the tendon. That could be a rotator cuff tear. Sometimes patients will have pain. They come in and they say, I've got pain right here, right here. What do you think? How would you evaluate that?
Well, pain in the front or anterior part of the shoulder, again, we still do consider pathology in the shoulder. It could be tendinitis, it could be bicep tendinitis, it could be something deeper down, possibly arthritis, especially in the older population. It could also still be referred pain from the neck, and it can involve other structures like what's called the brachial plexus, which is a bundle of nerves in that area, and we need to be concerned to see if there are any other symptoms besides just anterior shoulder pain.
Interesting. Very often, when I see the shoulder pain and they're up here, I ask them, I'm sure you do too, did you have any trauma? Did you fall? Did you hurt yourself? Did you dislocate your shoulder? If there was no dislocation and no trauma, I would agree the biceps tendinitis are probably one of the more common issues for sure. But sometimes there is no trauma. Sometimes there is no kind of developing issue. And the concern is what it is. What about if a patient comes in with back of the shoulder pain, posterior shoulder pain?
Again, same thing as Dr. Popovitz mentioned. Was there any trauma? Was there any dislocation, perhaps? That to me, is more of a shoulder problem. When it comes to the back of the shoulder, especially where Dr. Popovitz is pointing in that area. If it's higher up, as we started talking, that's probably more muscular and trapezius involvement. But if it's around the back, directly back of the shoulder, then yeah, we're concerned that there's some problem with possibly the rotator cuff or the labrum, or some kind of shoulder involvement, pathology.
Absolutely. A lot of times, the posterior shoulder pain, the back of the shoulder pain, very, very often can be torn cartilage inside the shoulder itself. The labrum, as Dr. Mizhiritsky mentioned, is a cushion of cartilage that sits between the ball and socket joint. It's a cushion right in the socket area. And very often, a lot of young people will develop tears there from traumatic events or from overhead athletics or from a lot of weightlifting, lifting something too heavy. Throwing athletes get it very, very often. A lot of that occurs. And a lot of times that pain is insidious. It develops in time. It's not right away. It develops, I've been working out lately in the gym. I'm doing these new reps. And I started to get this pain. Now it's getting worse. Sometimes people get clicking. They feel that clicking inside the shoulder. That's very common with labral tears.
So if I may ask you, Dr. Popovitz, how would you treat a labral tear in a 30-year-old?
So a 30-year-old with a labral tear, more often than not, is traumatic. Something has occurred to it. If it was, say, it was like 20, 30 years older and there was no trauma, it's probably degenerative. So if it's a 30-year-old with a labral tear, more often than not, it depends upon the symptoms and the location of the tear. If the patient is not unstable, where the shoulder does not come out of the socket, and the joint does not look too unstable or disruptive, you can actually treat it conservatively first with some physical therapy, kind of strengthening, scapular strengthening. You want to get that scapula in its place, the wing bone in the back, focus on that, postural exercises. Very often that does the trick, very, very often. Unfortunately, sometimes it does not do the trick, and sometimes we have to repair the labrum. In older people, where it's degenerative, insidious, kind of gradually develops, more often now we can treat it non-surgically. Patients do very well with non-surgical treatment in that case. Now, if the patient's unstable, or the shoulder keeps coming out of the socket, or if the pain does not get better with a month or two of physical therapy, usually a month or two is a good litmus test. A month or two of physical therapy, you're not better, and you have a documented labral tear, more often than not, you really do need to have that fixed. It's also location is very important. If it's right under where the biceps tendon attaches, so that biceps muscle that we have right here, it travels all the way up into our shoulder and it turns into a tendon. So it's nice and big over here, but when it goes all the way up into your shoulder, it turns into a very thin tendon and goes into the joint and attaches on top of the socket, So the shoulder is a ball and socket joint. On top of the socket, the biceps tendon meets the labrum. They meet together right at that spot, and that's a very, very common spot for a tear. And the labrum and the biceps tendon become unstable. It tears off of the bone. That's often very, very painful and very surgical repair. If it's a stable labral tear on the peripheral side that causes no instability, those people usually get better with physical therapy. And they really do.
Interesting. What would you say the success rate for a labral repair would be?
Exceedingly high. Mm-hmm. Exceedingly high. Patients do fantastic with labral repair. Mm-hmm. Absolutely. And it's minimally invasive. Mm-hmm. Minimally invasive.
Do they need any more treatment beyond that, such as physical therapy?
Well, there's post-operative rehabilitation. Once they're done, they can go back to professional athletes. We've treated plenty of professional athletes for labral repairs, all kinds of repairs, but labral repairs, they go right back. Once they fully recover, they go back. They can't wait to go back. Sometimes they come back and they forget, they come back with other complaints. They forget which joint was bothering them.
Very good. Thank you.
Thank you. Well, thank you very much for joining us tonight.
My honor.
I think we covered most of the kind of mutual covers between neck and shoulder. A lot of times the neck and shoulder has a lot of overlap, and sometimes for a doctor there has to be a little investigation as to, is it coming from the shoulder, is it coming from the neck?
Sometimes it could be both.
Yes, absolutely true. Well, thank you very much for joining us, and we look forward to seeing you again.